بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we'll continue the subject of lymphatic system imaging, and we will now discuss the issue of lymphoma, and this will be covered through about 3 lectures. Then this is the first one. We would like to have some introduction about lymphoma, then we will cover these issues for the first lecture, with concerning the CNS lymphoma, the spinal cord, and the head and neck. Then we'll follow these subjects later on, inshallah. In the CNS, we would like to say something about the parenchymal lymphoma, leptomeningeal, the dural and subependymal, and the immune-related lymphoma. Then in the head and neck, we want to talk about orbital lymphoma, salivary gland lymphoma, sinonasal, pharyngeal and laryngeal, as well as the thyroid disease. You know that lymphoma is the malignancies that is arising from the lymphocytes or lymphoblasts. Lymphoma accounts for around 4% of all cancers, and in children it represents a higher percentage in the range of 10 to 15% of all cancers. And lymphoma may present as a nodal disease or extranodal disease. Hodgkin lymphoma, as well as low-grade non-Hodgkin lymphoma, usually present by nodal disease, while the high-grade non-Hodgkin lymphoma usually present as an extranodal disease, which can affect any organ in the body. There are some risk factors for the development of lymphoma, including the viral infection, especially the HIV, bacterial infection, especially the Helicobacter pylori bacteria. And you know that chronic immunosuppression, especially in those who are performed organ transplant and they are receiving immunosuppressive drugs, are prone to develop this lymphoma, and also some chemotherapeutic drugs may predispose for the development of lymphoma. And this is the very old staging system of lymphoma, considering the stage 1 as a primary lesion only in the node or the bone or other tissues, and the stage 2 nodes in more than 2 anatomic regions on the same side of the diaphragm. That the stage 3 are nodes in both sides of the diaphragm, and the stage 4 the presence of metastatic disease. And Hodgkin lymphoma represents about 40%, while non-Hodgkin lymphoma represents about 60% of the lymphoma. And the types of non-Hodgkin lymphoma include the mature B-cell lymphoma, which is the most common, and the mature T-cell lymphoma, and also NK cell lymphoma, and post-transplant lymphoproliferative disorders. Lymphoma, whenever it is diagnosed or strongly suspected, it is recommended through the literature to have a whole body contrast enhanced CT, since the PET CT is, according to the literature, insufficiently sensitive to detect bone marrow lesions, and also the brain and liver have a normal high background FDG uptake that may obscure small lesions, for example. And you know that MRI is very helpful in the brain, in the spine, head and neck, and musculoskeletal system. Also, you should know that diffuse large B-cell lymphoma is the most common histologic type of non-Hodgkin lymphoma. Lymphoma in general usually do not invade the tissues, but has the tendency to encase or surround the adjacent structures. And we'll start by the CNS lymphoma, and you know that the brain does not contain any intrinsic lymphoid tissue. And the origin of lymphoma is suspected in the CNS to arise from the pre-adventitial cells in the vessels penetrating the Burkitt-Robbins spaces. And this assumption may explain that the lymphoma is usually distributed in the periventricular and the subependymal regions. According to the literature, the primary CNS lymphoma is rare and it represents about 1% of non-Hodgkin lymphoma. And while the secondary lymphoma, which means that intracerebral involvement in the systemic disease, is about 10 to 15% of cases, then lymphoma should be included in the differential diagnosis of an enhancing extradural mass, which is sometimes mistaken for a meningioma. Then if you look here and you see in this MRI axial T1 weighted image after contrast injection, you see a homogeneously enhanced lesion that is based to the dura, fulfilling the diagnostic criteria of a meningioma. But in this particular example, you see that the lesion has eroded the bone and it has an extracranial component, and these findings are not seen usually with lymphoma, since meningioma usually has an osteoblastic activity. It results in thickening of the bone with no tendency to invade the bone and extend in extra cranially. Then in primary lymphoma is classified as these types: indolent, aggressive, and highly aggressive. And then according to the literature, in the indolent type, then 3%, in aggressive type, 9%, and the very highly aggressive type, 27% risk of developing secondary CNS lymphoma. And the mean age for the development of lymphoma at many sites in the body is about 50 years of age. The male predominance is about 2 to 1, with a short duration of symptoms for a few months, as usually seen in the clinical practice. The predisposing factors for CNS lymphoma are the same for other parts in the body, especially the immune suppression, especially those with HIV infection, and the presence of Epstein-Barr viral infection, post-transplant, and other immunodeficiency syndromes. In this particular example, you see a classic case of lymphoma. This is axial T1, T2, flare, diffusion, and the T1 post-contrast. In most of the cases, the lymphoma is located in the supratentorial area, but it can occur also in the posterior fossa, and frequently it lies very near to the ventricle. It has a subependymal location. It can cross the midline through the fibers of the corpus callosum. Lymphoma is usually hypo to iso-intense in the T1, and the same in the T2. It may show some signal increase in the flare images, and it usually shows intense homogeneous contrast enhancement, and these findings are especially noted in immune competent patients with lymphoma. Shows minimal perifocal edema, and also it shows minimal mass effect. Lymphoma in the diffusion weighted images, it will show diffusion restriction, as you can see here. Then the criteria of lymphoma in an immune competent patient is the presence of a slightly hyperdense lesion in the CT. The lesion is in the pre-contrast CT. The lesion is located in near the ventricle in the subependymal area. The lesion will show a strong contrast enhancement both in CT and MRI, and it will appear of relative ISO and 10 signal in both T1 and T2 weighted images with some signal increase in the flare, minimal perifocal brain edema, minimal mass effect compared to the size of the tumor itself. And this is a frequent appearance of lymphoma which affects the dura. You see here a dural-based lesion that is homogeneously enhanced with no significant or no detectable perifocal brain edema, and there is also a little mass effect. And this is another example of dural lymphoma. You see a lesion that is not that homogeneously enhanced. There are some non-enhancing areas within the lesion, and the lesion is located outside the dura with little perifocal edema and little mass effect. In the CT scan, in the primary CNS lymphoma in an immune competent patient will appear relatively hyperdense in the pre-contrast scans, and it will show a strong homogeneous contrast enhancement after injection of contrast. There will be some perifocal edema and some mass effect, but the presence of hemorrhage, calcification, and necrosis are considered uncommon features in patients in immune competent patients. And this is an example. And you see multiple subependymal periventricular lesions that are relatively hyperdense in the pre-contrast scans. The lesions are surrounded by minimal perifocal brain edema. They involve the splenium of the corpus callosum, and they are crossing the midline, and they exert a little mass effect on the adjacent ventricles. And this is another example, and you can appreciate that the appearances of lymphoma are quite variable in the immune competent patients. Some of the lesions will show significant perifocal brain edema, other lesions will show minimal perifocal brain edema. But in my opinion, most of the lymphomas in the immune competent patients will show homogeneous post-contrast enhancement. And that's why they are included in the differential diagnosis of meningiomas, especially if they are dural based. And here you see the T2 weighted image, intermediate signal lesions, and in the FLAIR, intermediate signal lesions as well. After contrast enhancement, they show strong homogeneous post-contrast enhancement. Significant perifocal brain edema is seen here with compression of the ventricle and extension across the midline through the genu of the corpus callosum. And in the diffusion weighted images, one of the tumors that can show diffusion restriction is the lymphoma. And this is another example, the FLAIR image with some perifocal brain edema around the lesion, T1 post contrast, homogeneous strong enhancement with surrounding perifocal brain edema and a mass effect on the adjacent ventricle. In lymphoma in immune compromised patients is quite different. And primary CNS lymphoma is seen in 6% of patients with HIV infection, and it is usually of the high-grade B-cell non-Hodgkin type. And Epstein-Barr virus is usually detected in the CNS of these patients. 40 to 75% of the lesions are in contact with the ependyma or the leptomeninges. And you see multifocal lesions in about 50% of the cases. And also in here, hemorrhage, calcification, and necrosis. Necrosis is usually seen in these patients so that you can sometimes mistake this lesion for a glioma or even an abscess. And this is one of the well-known features. Lymphoma in immune-compromised patient may simulate an abscess. In the T1, in the pre-contrast CT scan, you see the lesion which is relatively hyperdense, some perifocal brain edema around, and after enhancement, you see a strong enhancement in the diffusion weighted images, and you see restricted diffusion. And in order to differentiate the abscess from lymphoma, you may use one of the isotopic scans using the metabolic tracers. Then you can differentiate between the abscess where there is no metabolic activity, and the lymphoma where there is metabolic activity. And this is an HIV patient with headache. The MRI, the T2 showed this lesion with significant perifocal brain edema. This is the FLAIR image, and this is the T1 post contrast. You see a marginally enhancing lesion with a central no enhancement and a significant perifocal brain edema. And this lesion is indistinguishable from glioma, for example. And in the diffusion weighted images, the enhancing margin, which means that the viable tumor tissue will show diffusion restriction, and this is the surrounding perifocal brain edema. Then, according to the literature, whenever you are confronted by a lesion like this in an HIV positive patient, the differential diagnosis is only two. Either this is a toxoplasma abscess or a CNS lymphoma. And many times you may go by biopsy to differentiate between both. But if you use some of the isotopes using the metabolism on the basis of scans like the Salium SPECT, for example, then if there is uptake of this isotope through the lesion, you can say that this is lymphoma. But if not, or the uptake is weak, then you say that this is toxoplasma, for example. And as I know, in many situations, this is not enough, and the diagnosis should be confirmed after that by biopsy. The secondary CNS lymphoma is the lymphoma secondary to a lymphoma present elsewhere in the body. And these types of lymphomas usually involve the leptomeninges, and they may manifest by headache, cranial nerve pulses, and sometimes by seizure. And whenever you are confronted by an appearance like this in the CT or in MRI, where you can see enhancement through the CSF spaces, what we call leptomeningeal enhancement, then the differential diagnosis is between infection and the tumors. On the top of infections is the tuberculous meningitis and sarcoid, and on the top of tumors, lymphoma, and leptomeningeal metastatic deposits. And this is a biopsy proven primary CNS lymphoma affecting the dura as well as the cerebral parenchyma in the temporoparietal area with a strong, almost homogeneous contrast enhancement, some perifocal brain edema around, and a considerable mass effect on the adjacent ventricle with contralateral shift of the midline structures. And this is periventricular subependymal lymphoma before treatment and after treatment. T2 diffusion weighted image and T1 post contrast. You see the enhancement around the wall of the ventricle, and and sometimes whenever you see this and you don't know the clinical picture of the patient, which is usually not helpful in many cases, the differential diagnosis is one of three. If you see subependymal enhancing lesions like this, number one is lymphoma, number two is metastasis, number three is glioblastoma multiforme. And this is lymphoma, and you see after treatment, lymphoma is one of the lesions that responds well for the treatment. Then lymphoma is very rare, affecting the pituitary gland. And the lymphoma of the pituitary gland can be either primary or secondary, a part of a systemic disease. Lymphoma of the pituitary gland do not affect the function of the gland, and it does not usually produce a bulky mass. The appearance is usually of a lesion that cannot be distinguished from the more common pituitary macroadenoma. And here you see a marginously enhanced lesion occupying the cella, and it has a small supracellular extension. And you need the biopsy to confirm the diagnosis of pituitary lymphoma, since this is a very rare condition. But frequently we diagnose this as pituitary adenoma, which is of course more common. And you go by transsphenoidal, for example, biopsy to see or to confirm the diagnosis. And lymphoma also can affect the spinal cord, and it accounts for 3.3 of all CNS lymphoma and 1% of all body lymphomas. The mean age of presentation, as I have mentioned before, most of the lymphomas present around this age, which is 50 years. And females here are more commonly affected than males, and the clinical presentation is almost similar to any intramedullary tumor like the glioma and ependymoma, for example. The risk factors are almost the same: the AIDS patients, organ transplantation, congenital immune deficiency, and Epstein-Barr virus infection. The lymphoma of the spinal cord is usually diffuse. It results in a swelling of the spinal cord and a change of the parenchymal signal, like this. This is the T1 and this is the T2. You see diffuse swelling of the spinal cord with increased T2 signal, and many times you see that the lesion is not significantly enhancing after contrast injection. The diagnosis of lymphoma is usually confirmed by CSF cytology, where you can identify the malignant cells. And this is a spinal cord lymphoma. Here you see in the T1 weighted image, the T2 and the T1 post contrast. In this case, you cannot say that this is lymphoma, but you have to diagnose the two other more common pathologies, which are the astrocytoma and the ependymoma. And both lesions are usually associated with a cyst in the spinal cord. The cyst is part of the tumor in cases of astrocytoma, and it is not part of the tumor in cases of ependymoma. And as I have mentioned before, the discrimination between both is almost impossible by imaging. Then lymphoma is not usually associated by cystic changes in the cord, and the enhancement is usually poor. Then these are the criteria of lymphoma in the spinal cord: no tumoral cyst, no syringomyelia, no hemorrhage, and poor enhancement. And this is an example where you see a longitudinally enhancing lesion within the substance of the spinal cord, and this is the appearance in the axial image. This lesion is appreciably enhancing, as you can see here, and this was confirmed to be a lymphoma. This appearance is more commonly seen in the clinical practice lymphoma in the epidural space or even in the paravertebral space. You see a soft tissue mass, and this mass has a component in the epidural space. This component is of intermediate signal in the T1 and T2 weighted images, and after contrast injection it shows homogeneous enhancement, as you can see here. The main differential diagnosis here is metastatic disease. You see the extension of the lesion in the paravertebral, as well as involvement of the back muscles. And this is a case of lymphoma extending along the nerve roots. And you see here this patient known to have in advancing B-cell lymphoma presented with paraparesis and sphincteric disturbances. The MRI before and after contrast showed the thickening of the nerve roots and enhancement. Considering the patient clinical condition, you should say that this is the sequelae of lymphoma. Then we came to the lymphoma of the head and the neck, and is considered the second most common malignancy, of course, after the squamous cell carcinoma. Lymphoma represents about 5% of the head and the neck malignancies, and 15% of patients with systemic lymphoma have head and the neck involvement. The lymphoma in the head and neck is usually of the non-Hodgkin type, and the presentation depends upon the site of involvement. Cervical lymphadenopathy presenting as palpable masses, affection of the Waldeyer ring and the tonsils, the salivary glands, the paranasal sinuses, the orbit, and the thyroid gland. Non-Hodgkin lymphoma is about 10 times compared to the Hodgkin disease in the head and the neck. And in both conditions, you may say widespread lymphadenopathy, and you remember that the nodes of lymphoma are usually bulky, homogeneously enhancing, may be amalgamated, do not contain calcium. The most common site for extranodal involvement by non-Hodgkin lymphoma is the Waldeyer ring. The association between Waldeyer ring and the GIT involvement is seen in about 10% of the patients. Lymphoma, as I have mentioned, is second to the squamous cell carcinoma in head and neck malignancies. Then how can you discriminate between both? These are some of the suggestive features to separate or try to separate squamous cell carcinoma from lymphoma. In cases of squamous cell carcinoma, the metastatic nodes usually show central necrosis, and this carcinoma is invasive. It destroys the skull base with intracranial extension. Lymphoma do not show this aggressive character. Also, absence of distant nodal or extranodal disease, which is seen frequently in cases or in patients with lymphoma. And orbital lymphoma represents about 2% of all lymphomas, 10% of all extranodal lymphomas, 50% of all primary orbital malignancies, and is considered one of the commonest orbital tumors. The usual type is the B-cell non-Hodgkin lymphoma, and the age of presentation is usually similar to lymphoma elsewhere in the body, around the 50 years of age. 25% of patients have conjunctival lymphoma, will present by this very characteristic salmon red patch like this one, and this is the presentation of conjunctival lymphoma, which can be diagnosed clinically. And most of other lymphomas in the orbit are usually in the vicinity of the lacrimal gland, but intraocular lymphoma is very rare. Optic nerve lymphoma is also rare. Then, if you remember my talk about the orbital lesions, and you see I have mentioned that lymphoma is characterized by multiple intraorbital homogeneously enhancing lesions, and that the bilaterality is one of the suggestive criteria, and also the tendency to encase the globe, as you can see in this particular example, and this is one of the suggestive criteria of lymphoma, although metastasis can do a similar appearance, but you need the history and you need the clinical data of the presence of a primary malignancy in order to diagnose this as metastatic disease. And this is another case of orbital lymphoma in a male 79 years old presenting by proptosis. There are diffuse involvement of the orbital cavity, encasement of the globe, encasement of the optic nerve by homogeneously enhancing soft tissue masses. And you can easily appreciate the absence of destructive changes in the bone or aggressive reaction of the tumor. The lacrimal gland is one of the common sites of orbital lymphoma, and this the involvement may be unilateral or bilateral. And you remember that I have said that if you have bilateral lacrimal gland masses, and this means that you are dealing with a systemic disease, and one of the differential diagnoses is lymphoma. Then here you see unilateral lacrimal gland involvement. And in cases of unilateral involvement, your diagnosis should be either inflammatory or neoplastic. The neoplastic either primary or secondary. And you should include in the differential diagnosis lymphoma, of course. Then these are the orbital sites of lymphoma, the conjunctiva, as I have mentioned, the lacrimal gland, the intraorbital fat, as seen in the previous examples. The intraocular lymphoma, as I have mentioned, is very rare, and the lymphoma tends to mold itself around the orbital structures. It tended to encase the orbital structures, not to invade the structures. And this is MRI T1 boost contrast showing a mass in the left lacrimal gland. And this mass was proved to be a lymphoma. And this is the follow-up scan after chemo and radiotherapy showing total regression of the disease. In salivary gland lymphomas represent about 17% of the head and neck lymphomas, usually affecting the parotid gland, which is considered the most common type. In all parts of the body, it is usually suggested that the primary lymphoma is relatively rare compared to the secondary type. And here you see a mass affecting the right parotid gland, extending into the deep lobe close to the parapharyngeal space. And this mass should be included in the differential diagnosis between primary malignancies, secondary malignancies, and they consider also the lymphoma. And this huge mass infiltrating the left parotid gland was proved by biopsy to be due to Hodgkin lymphoma. And this is a left parotid gland mass, and the mass is almost homogeneously enhanced. It affects the superficial lobe, and the rest of the scan showed some small lymph nodes around the submandibular salivary gland and other lymph nodes on the opposite side. And you can also see this lesion, which is enhancing, and the pathology was proved to be follicular lymphoma. You remember, if you have bilateral symmetrical enlargement of the parotid glands with intracystic changes, then the differential diagnosis will be Hodgkin lymphoma, Sjögren disease, and the benign lymphoepithelial lesions which are HIV related. And sometimes they include in the differential the Wharton tumor and also the sarcoid. But I think that this appearance is particularly seen in Sjögren and in non-Hodgkin lymphoma, which is intimately related to the Sjögren disease, and also in AIDS patients with benign lymphoepithelial lesions. In differential lymphoma, it also affects the naso and oropharynx. It presents by a mass which is in most of the cases indistinguishable from the carcinoma. And whenever the mass is unilateral and is not associated with significant cervical lymphadenopathies, then the diagnosis should be the squamous cell carcinoma. But if the mass like this, which is centered in the midline, affecting the nasopharynx, obliterating the nasopharynx, encroaching on the parapharyngeal spaces bilaterally, and is associated with bulky, homogeneously enhanced lymph nodes, then the diagnosis may be suggested as lymphoma. This is the same case with MRI T1 post-contrast with fat suppression, and this is in a PET CT image, and here is the sagittal T1 post contrast, and you see a nasopharyngeal mass which is centered in the midline, extending to both sides. This is most likely suggestive of lymphoma rather than squamous cell carcinoma. And this is another example in a female 65 years old. You see the mass in the midline, low signal in the T1, relative high signal in the T2, homogeneous post-contrast enhancement, bulky, homogeneously enhanced lymph nodes on both sides. Then you think of lymphoma. But if you see a mass like this, which is affecting the wall of the pharynx on one side, and if you look carefully in the neck, there is no significant lymphadenopathy, then don't rush for the diagnosis of lymphoma, since squamous cell carcinoma is much more common than lymphoma in this area. And the diagnosis should be squamous cell carcinoma. Then in the differential diagnosis, you may include the possibility of lymphoma. And this is an example of oral cavity lymphoma, a mass which is eroding the alveolar margin. And this is also not a feature of lymphoma, it's a feature of squamous cell carcinoma. But the diagnosis should be squamous cell carcinoma, but after biopsy, it proved to be lymphoma. And here you see a mass in the left side of the oropharynx, inseparable from the base of the tongue, and you see the bulky lymph nodes in the neck. Then the diagnosis of tonsillar lymphoma is suggested and proved. And if you look here, and there are bilateral enlargement of the tonsils, almost obliterating the airway, and you see multiple variable sized lymph nodes in the submental area and the supraclavicular area, and also deep to the sternomastoid muscles. Then this is proved to be tonsillar lymphoma. And sinonasal lymphoma represents about 24% of the head and neck lymphoma. And the commonly seen type is the B-cell non-Hodgkin type. And nasal cavity lymphoma is usually of the T-cell type. And the lymphoma of the paranasal sinuses, of course, have the ability to involve the orbit, the nasopharynx, the jaw, the hard palate, and the cheek, and also it may extend intracranially. And sometimes lymphoma can be missed as an inflammatory sinus disease. But if you look carefully here, this sinus is obliterated, good, but the wall is eroded. And moreover, you see a soft tissue mass infiltrating the infratemporal fossa muscles, including the masseter as well as the pterygoids, with obliteration of the fat planes here. And this is not usually seen in cases of sinusitis. And whenever you are confronted by this, since lymphoma has no aggressive characters in most of the cases, and you should be careful for the diagnosis of lymphoma. And this is another case of lymphoma that may be mistaken for fungal sinusitis, but here this is the post-contrast image in the in the CT axial image and the coronal. This is bone window. You see bulky masses that are homogeneously enhanced, and these masses are eroding the orbital floor, eroding the medial wall with intraorbital extension. In laryngeal lymphoma, if it presents by a single unilateral mass, usually cannot be discriminated from the more common laryngeal carcinoma. But this diagnosis can be reached by biopsy, and if you see bilateral lesions, a lesion on the left and a lesion on the right, then the lymphoma is highly suspected. And also, if you see a lesion with bulky lymph nodes, then you think of lymphoma. In the literature, the dolphin node is a prelaryngeal midline lymph node that can be used as an indicator for the subglottic malignancies. And this is a case of lymphoma that can be suggested easily from the imaging because of the presence of bilateral bulky masses. And this is T1 and this is T2 and this is T1 post contrast, and bilateral masses affecting the larynx. And also you see big lymph nodes on both sides, then you think of lymphoma, and this was lymphoma. And finally, the thyroid lymphoma represents about 5% of the thyroid malignancies and 7% of the head and neck lymphoma and 3% of extranodal lymphoma. The thyroid lymphoma is usually of the primary type, and the age of presentation is around the 50 years of age. And most of the thyroid lesions have predominance towards the females. One of the predisposing factors for thyroid lymphoma is the presence of Hashimoto thyroiditis. The diagnosis of lymphoma is suspected clinically whenever you see a rapidly enlarging thyroid mass with compressive symptoms, of course, on the trachea and the esophagus, as well as palpable cervical lymphadenopathy. And you see here big mass affecting the thyroid gland, especially the isthmus and the right lobe. Usually you cannot predict the lymphoma of the thyroid from imaging, since the malignancy of the thyroid can simulate the appearance of lymphoma. But it is stated in the literature that the diffuse involvement of the thyroid gland, both lobes as well as the isthmus surrounding the trachea, producing the characteristic donut sign, are some of the imaging criteria to suspect the possibility of lymphoma. Then thyroid lymphoma may present as focal mass, which cannot be differentiated from carcinoma, or multiple thyroid nodules, which cannot be discriminated from nodular goiter, and diffuse enlargement of the gland, which can be seen in other lesions. Then you know that lymphoma do not usually contain calcium and do not usually show central necrosis. And you remember that this type, the rarest type of thyroid cancer, which is the anaplastic type, is presenting by big masses but with central areas of necrosis. And cervical lymphadenopathies of the bulky type are usually seen in cases of thyroid lymphoma. Thyroid lymphoma represents about 5% of thyroid malignancies. It is usually of the primary type. 80% are associated with Hashimoto thyroiditis, and most of the patients, or it has a predominance in the females. Nodal lymphoma has been discussed in the previous subject, and you know that nodes of lymphoma are usually bulky, they are homogeneous, they do not contain calcium, they do not contain central areas of necrosis. And this is an appearance of lymphoma nodes in the submental area and in the deep cervical region, deep to the sternomastoid muscle. And you see also nodes around the submandibular salivary glands. Thank you. Alhamdulillah Rabbil Alameen.